Welcome again, everyone. Last lecture, in the part one, we conclude that health outcomes are primarily shaped by the social environment rather than individual willpower, with socioeconomic status serving as the strongest predictor of mortality. Also, we said that stress provides a physiological link between social standing and illness, directly compromising the immune system through processes studied in psychoneuroimmunology. While those with the higher socioeconomic status possess more coping resources like education and money, lower socioeconomic status individuals face chronic that accumulate into significant health risks. Understanding these environmental pressures is essential for exploring the social support system and behavioral models discussed in the part 2 today. So let's start. Social support. The Alameda County Study. This is the foundational study. Researchers surveyed residents of Alameda County, California, aged between 30 to 69 back in 1965. They measured physical, mental, and social well being, plus habits like exercise, smoking, and drinking. Crucially, they also mapped people's social networks, marital status, number of close friends and relatives, church membership, other affiliation. Then they track death certificate over 9 years and followed up with survivors in 1974. The findings reshaped the field. As expected, unhealthy behaviors predicted higher mortality. But the surprise was this person's health and risk of dying were strongly tied to extent and nature of their social network for both men and women at high and low socioeconomic status. And here the key, it held even after controlling for unhealthy behaviors. The headline numbers, people with few social contacts had mortality rates 2 to 3 times higher than those with many connections. Loneliness, in the other words, can be as deadly as smoking. And this was not a fluke. Confirming the social support effects. Review of 148 separate studies confirmed it. Much lower mortality of people with strong social connections. And the effect held regardless of age, gender, and pre-existing conditions. It's one of the most robust findings in the social epidemiology literature. The nature question is why? Why would having friends keep you alive? The honest answer is we are not fully sure, but there are three leading explanations. First, social support buffers stress. Emotional support from close contacts can even trigger protective hormonal responses. Second, it works indirectly. Peers can model healthy behavior, and belonging to a group can set norms around taking care of yourself. Third, social connection builds a sense of purpose, well being, and self esteem. And again, psychoneuroimmunology may eventually tell us exactly how these translate into longer life. So we have covered the big social factor, socioeconomic status, stress, and support. Now, the question becomes practical. How do we actually change behavior? Enter the psychological model. Now, psychological models of health behavior, the purpose. Let's be realistic about what public health can and can't do. We can't easily change someone's socioeconomic status, undo their stressful life events, or rebuild their social network. But if we understand how those factors affect health, we can design smarter interventions. So, behavioral scientists built models. Some focus on individuals' psychology, other on the social environment, all aimed at one goal: finding the most effective levers for healthier behavior. The classic starting point is the health belief model. The health belief model is the classic frame, and it's assume people behave rationally, that they weigh cost and benefits. It's say four factors determine whatever someone will change behavior in the face of a health threat. Number one, do they feel vulnerable to it? Two, do they think it is severe? Three, what barriers the action will actually work? Number four, do they believe the action will actually work? So, sorry. Number three, perceived barrier to taking action. And number four, perceiving effectiveness of the action. Okay, get all four lined up and behavior change becomes likely. Let me make this concrete with a real example. Survey of low income minority women who would never had a mammogram revealed exactly that breaks down the model predicts. Some underestimated their susceptibility. That's factor number one. Others were embarrassed or afraid of pain or radiation. That's the barrier factor number three. And some believed cancer was incurable anyway. So, why bother detecting it early? That's factor number four, perceived ineffectiveness. The takeaway is powerful. You can't use one genetic message. Personally tailored counseling that addresses each woman's specific belief could rise screening rates. But the model was missing something, and that something is self efficacy. Self efficacy. Self efficacy is the sense that you have control over your own life. People with high self efficacy are confident they can steer their own course. People with low self efficacy feel their lives are at the mercy of a chance or outside force. It is so important that it is often bolted onto the health belief model as a fifth factor. Because even if you believe a behavior would help, you won't attempt it unless you believe you're capable of doing it. And a sense of control does good thing for health in several ways. Control stress and learned helplessness. For one, control reduces stress. Studies in humans and animals shows that the perceived stressfulness of a bad event drops when you know when it's coming and can regulate its timing and intensity, both of which give a sense of control. Now, flip that. The lowest self efficacy is found in those who have tried and failed repeatedly to escape something painful. They developed what's called learned helplessness, a numbed acceptance of a bad situation where the person stops trying to improve it because they no longer expect their effort to matter. It's hard to breaking but important concept, and it shows up directly in health behavior. Self-efficacy and healthy behavior. The research is clear. People with high self-efficacy are more likely to engage in healthy promoting behavior. And learned helplessness is painfully common in exactly the people we most want to help, those who have tried again and again to quit smoking or lose weight and failed. They have concluded they simply can't. So the practical question becomes, how do we build self efficacy in people? Two main routes to increase self efficacy. First, previous success at the behavior. Nothing's, nothing builds confidence like having done it before. Second, watching similar others succeed. And that second route has striking implication for program design. The most effective school drug prevention programs use role modeling, small group exercises, and skill practice. But here the kicker. They work for better when led by older teams the kids can identify with, rather than by adult health educators. Relatability is the active ingredient. Now, let's look at the model that maps behavior change as a journey. The Transtheoretical model, five stage of change. The Transtheoretical model, also called the stages of change, see change as a process with five stages. Number one, pre-contemplation, no intention to change. Here you do consciousness rising to build awareness. Number two, contemplation. Contemplation. They see the benefits but are hung up on the barrier not yet ready. Number three, preparation. They have decided and are making concrete plans, signing up for a class, talking to a doctor, buying a self-help book. Number four, action. They actually doing it. And finally, number five, maintenance. They have it changed but must guard against relapse. The practical genius here is that knowing someone stage tell you exactly how to nudge them to the next one. You wouldn't hand a pre-contemplators a quit smoking plan. They are not there yet. So how do these two models relate? Don't think of these as rival theories where you must pick a winner. They are not contradictory. They are alternative lenses on what may be the same underlying psychological factor. And both are genuinely useful when designing public health messages. So far, though, everything's been about the individual head. The next model deliberately widens the frame to the whole social world. The ecological model of health behavior. The ecological model takes seriously what we said at the very beginning, that beliefs and behaviors happens in a social context, and that changing the environment may be more effective than changing the person. It examines how interpersonal, organizational, community, and public policy factors all support and maintain unhealthy behaviors. And its core proposition in hopeful change those surrounding factor, and individual behavior will change with them. The model has clear structure, five nested level. Look at the five nested level, five levels of influence. At the center, level 1 is interpersonal, the individual's own knowledge, attitude, and skills. That's territory of all those psychological theories we just covered. Then it's widen, level 2, interpersonal, family, friends, and co-workers. Level number 3, institutional, school, workplace, Level 4, community, local organization, network, and values. And level 5, the, the outermost ring, public policy, laws, and regulation. Each level is a potential intervention target, and crucially, the outer levels shape behavior both directly and by interacting with the inner ones. Let's walk through them because the strategy shifts at each level. Start with level 2, the interpersonal. Interpersonal relations. Family, friends, and coworkers have powerful effect on health behavior. Families are where we learn our earliest habits, toothbrushing, exercise, and eating patterns. Then, the teen years, peer pressure takes over a dominant force behind smoking, alcohol, drugs, and risk taking. But it's not all negative. These same family and peer relationships are the source of social support we discussed earlier. Now, up a level to the institutions where people spend much of their lives. Consider this: people spend one third to one half of their working lives in institutions, mainly schools and workplace. So these settings powerfully shape health. The workplace can harm hazardous chemicals, injury risk, stress, or it can help a corporate culture that supported change, healthy cafeteria menus, exercise facilities. You are encouraged to use smoking restrictions because they are captive. Structured environment, schools, and workplace are ideal intervention settings. Move out one more ring to the community. The large community can sway behavior significantly, and organizations can join forces to push healthy goals. Knowing a community structure reveals opportunities. For example, churches are the social hubs of many black and rural communities, making them natural focal point for healthy interventions. On the other side, there is the mosques also. Many Muslims are making them natural when they pray, so increase the health. But community factors can cut the other way too. In the tobacco growing south in the United States, where tobacco, like in Texas state, uh, where tobacco is a pillar of local economy, public health advocates may struggle to even raise the topic of smoking harms. The economy itself resists the message. And finally, the outermost ring, public policy. Public policy is the outermost level. The regulation and limits on behavior we discussed the previous chapter. These are the most explicit and the most controversial tools government wield. Smoking restriction, minimum ages of alcohol sales, seal belt laws, and so on. They are blunt but powerful. Program must be sustained. Health promotion can never be mission accomplished. These programs must be repeated for every new generation and every new at-risk group. It's changing the environment. Many advocates now argue that the real leverage is not nudging individual. It's in changing the social and physical environment so the healthy choice becomes the easy choice. The best example, motor vehicles death have have plummeted over 3 decades, and that came far less from safe driving education than from safer design, better engineered highways and cars. We changed the environment, not just the driver. The same logic applies elsewhere. The environment heavily shapes what we eat and how much we move. The government says eat 5 to 9 serving of fresh fruits and vegetables daily, but educating someone in a poor neighborhood is pointless if there is no supermarket or produce stand within reach. That's a food desert. Similarly, federal policies since World War II that favored is suburban uh, deserved much of the blame for our lack exercise. Americans live in their cars because nothing is within walking distance. You can't lecture people into walking if there is nowhere to walk. This reframes the entire enterprise. Public health as collective action. The environmental perspective forces us to see public health problems as social and political issues demanding collective action. Watch the shift in thinking with tobacco. Instead of blaming the smokers of weak willpower, public opinion turned toward the tobacco industry and the fortune it spent making cigarettes appealing to the young, and that reframing produced a remarkable change in attitudes. There is a parallel with black activities who confronted the alcohol industry over its aggressive marketing of high powered malt liquor to young black men. Now, this approach means picking fight with powerful economic interest, and it won't always win. But getting whole communities involved has the greatest potential of all the drive measure the change. Let's pull the chapter together to summarize it, or let's consolidate. Because behavior so strongly drives health, understanding what shapes behavior is essential, and the social and behavioral sciences give us that foundation. We saw the race, gender, marital status, and especially socioeconomic status influence health, largely through the social environment. On the other hand, life expectancy, infant mortality, and disease mortality vary profoundly by racial and ethnic groups. Stress often socially caused harms health through multiple pathways, while social supports protect it partly by buffering that stress. And Black Americans' health remains poorer than the white majorities, which is why public health analyzes data by race and ethnicity and works to eliminate these disparities. On the theory side, the health belief model and self efficacy focus on individual attitude and beliefs. The trans-theoretical stages of change model guides health education by meeting people where they are, and the ecological model zooms out to all levels of influence: interpersonal, institutional, community, and public policy. The big lesson is that most effective programs work on several levels at once to build an environment that favors healthy behavior. Increasingly, the field recognizes that the most effective path runs through whole communities, reshaping their social and physical environment. This is the end of this chapter. Thank you for your attention and goodbye.